Uh, so we can start, please. Yeah. Good afternoon, everyone. It gives me immense pleasure to be moderating today's session on spinal muscular atrophy from awareness to action, and to introduce Professor Sheffali Gulati. Dr. Sheffali, as everyone knows, is a faculty in charge of Child Neurology Division. She's a program director and DM Pediatric Neurology program and co-founder from 2004. She's a faculty in charge of the Center of Excellence and Advanced Research for Childhood Neurodevelopmental Disorders in the Department of Pediatrics, AIIMS, New Delhi, and also an adjunct faculty at the National Brain Research Center. Professor Gulati, over to you to start the session.
I thanks the ORDI and Prasannaji for having me over. Let's just share my screen. The topic given to me is spinal muscular atrophy from awareness to action. And I thought of we go to the recognizing the clinical spectrum and red flags for a timely diagnosis and in the evolving therapeutic landscape, because so much has happened in the last decade, So, and the most important thing which many of the professionals as well as parents forget while chasing for disease modifying therapy is the role of multidisciplinary lifelong care to optimize the outcomes of children with SMA and to identify concrete steps to move from awareness to action, like newborn screening, treatment access schemes, the CSR, and community funded care pathways. This is a very timely webinar organized by ORDI because August is a global SMA awareness month, and the Cure SMA has designated August as SMA awareness month every year around 5 pillars of advocacy, giving, fundraising to educate and to raise the awareness. In India, Cure SMA Foundation of India had held a run for SMA 2026 on 9th August in Hyderabad, and the ORDI today's session is also part of it from the ODI. ORDI is also does a lot of races for SMA and various other rare diseases around the year to increase awareness. The shared goal is universal newborn screening. And here, very India-based, it may be more population carrier screening in the population, the equitable access to disease-modifying therapies, which is a very big ethical issue, and a sustained community support. And many, the rare diseases have been basically led by parents who have, themselves struggled and then established this non-governmental organization for supporting children with rare disease. And that's why hats off to Prasannaji for the same. And as we all know, SMA is an inherited autosomal recessive neuromuscular condition primarily due to the loss of alpha motor neurons. They are varying phenotypes with presentation across age groups, and primary management is multidisciplinary. The novel therapies have recently been developed that are showing considerable promise in combating the extremely poor morbidity and mortality associated with type 1, especially type 1 of SMA, and also its type 2. Over the last few years, there have been new emerging therapies in SMA, such as splicing modification of the SMN2 and SMN1 gene replacement. And, the SMA has something important. You have caused by the mutation in the survival motor neuron gene, but, the SMN2 is a backup gene, and SMN2 has a C to T base pair change, which is there, which causes the exclusion of the exon 7 when the mRNA is produced. So your SMN2 splicing modifiers like the risdiplam as well as nusinersen are functioning on this SMN2 splicing modification, and SMN1 gene replacement is what is being done by the Zolgensma, by the replacement of this the gene to the AV9 vector. They have been encouraging short-term outcomes in the term of motor function scores and life expectancy, and long-term outcome and adverse effect profile need to be investigated. So all the three are approved by the US FDA for SMA, but have a prohibitive exorbitant cost. A few humanitarian access programs have provided access to these medications, because of which we have also been following up many of these patients. The first gene therapy in India was done at our institute on 29th May 2020 in the peak COVID times. And then 2020 January was the first time Novartis started the global GMAP program for managed access programs on a humanitarian basis. Every 2 weeks, they were giving a lottery on a lottery basis. Two patients were identified globally for the same. So that's why we had many of these patients, and also for the nusinersen, Biogen through Global Direct Relief has identified 230 families in India for whom they have promised lifelong nusinersen. And we have had two such cohorts, and we've been following from one cohort from 2019 December and the other cohort from the March of next year. So and we had 12 in the first cohort and 35 in the next cohort. So a total of 47 children on nusinersen. As I mentioned to you, they were 12 and 36, but we had one patient who had expired. That's why I written 11. And we have had, for the Zolgensma, we have given 26 patients so far intravenous Zolgensma, out of which 18 were through the humanitarian access program of the Novartis, and the rest were either through crowdfunding or through the, the employees, programs through the we had the Coal India and Solar Energy Limited, as well as one patient from Jharkhand has had a state government providing the same. And Risdiplam, we've had 19 patients who have been on Risdiplam, out of which 5 were in the initial humanitarian access program, which was provided by Roche. All children have been receiving multidisciplinary care, including individualized physiotherapy, rehabilitation, nutrition care, and inpatient care in cases of severe respiratory illnesses. So out of the 26 patients who have received Zolgensma, they all have shown significant improvement in motor function. 18, as I mentioned to you, were 300 access and 8 by early access, in which I've explained in detail, out of which one patient was international patient from Kenya. Those with SMA2 who were initially unable to stand can now stand with orthosis. Those with SMA type 1 can sit independently without support and have showed improvement in job intent by at least 6 to 10 points. And one child expired due to tracheostomy tube-related complication, a mechanical complication unrelated to the drug, and 2 children passed away due to aspiration pneumonia. Most of our children had transaminitis. And thrombocytopenia as major side effect, which were managed by steroids, and only one required platelet transfusion. And tropi levels were also increased in many, but they did not have any symptomatic issue with the cardiac function. This SMN gene is sent through the AV9 vector into the human body. It doesn't integrate into the human genome. It stays separately inside the nucleus, and we, as the motor neuron has long life, we expect that the improvements seen are going to last for a lifetime, hopefully. But we have data as of now up to 7.4 years follow. All these patients, which I told you, practically all of our patients had transaminitis, and all these are reactions because of the host reactions to the AV9 vector. And we start the patient on steroids 1 day prior to giving intravenous Zolgensma. And recently, many of our patients have that combination. So they have been on Risdiplam. So we stopped Risdiplam 5 days before we start giving the intravenous Zolgensma. These patients are 26. We had 16 SMA type 1 patients, and and the baseline CHOP intensity, as we have mentioned. The intravenous gene therapy, if we have seen that all of them have shown significant improvement in they have shown improvement in the CHOP parameters for all of them, all the patients. And they had improvement in the bulbar function, respiratory status, and all. And so we see all of them have shown improvement. But mind you, from the data which has been shown initially, that the data which is there, which has shown that all these things improve. But if you give it to children in the first 6 weeks of life, they attain near normal motor milestones. But our patients were recognized later because we do not have the newborn screening taking place, which also is a dilemma and an ethical issue. So these were the other patients which and have shown all improvement. These are just representative. I don't want to give figures. You just try to, you see patient wise, then you see the improvement, and then you understand how much of the improvement in the real world scenario. This was the first patient of intravenous gene therapy in India on 29th May 2020. And this child, he did not even have head holding, and was dosing was done at around 12 months. His SMN type 2 copy, the SMN2 copy numbers were 3. And this child has shown an improvement in the chop thing. And the child can stand with gaiters and can sit without support. And these are the improvements which I've seen. This is another patient of SMA type 1 who did not have any neck holding, and bulbar weakness was there, and chop intent score has increased and has achieved a neck holding. The child has achieved neck holding. Initially, there was no neck holding. Has achieved neck holding and can sit unsupported, and no worsening of bulbar dysfunction, but requires nighttime BiPAP. So that is there. Giving an example of the oral risdiplam, we had 19 patients on risdiplam, on the Roche one. And something which is important for risdiplam, in 2017, orphan drug designation was granted, and 2019 there was a priority review status. On 7th August 2020, initially approved oral solution for SMA ages more than equal to 2 months, and that was based on their firefish and sunfish trials. And what they had shown was that, these children had significant improvement in motor milestones. But because of a rainbow fish study, in which, again, in the first 6 weeks, if they were started the risdiplam, they had achieved near normal motor milestones according to WHO standards at 1 year of age. And that's why on 31st May 2020, there was an expanded indication that all pre-symptomatic babies less than 2 months old were also approved for risdiplam, and now it is approved for all ages. On 12th February 2025, a tablet formulation has also been approved for ages more than equal to 2 years and more than equal to 20 kg. The bioequivalent study, first and only SMA tablet, the swallowing, or the putting in water. So all that has been done. So now even a tablet formulation has been approved, and it is currently approved for all ages, including the DCGI thing. This is something that DCGI approval for risdiplam came on 29 July 2021. So that was basically 1 year. On 7th August 2020 was FDA. So this was 29 July 2021, about 1 year after that. So it was 2 months and above. And they had launched a Blue Tree program. And in the Blue Tree support program, the child, was given some bottles free. The cost of bottles which were there, list price was 6 lakhs a bottle. So ultimately a cost came around 20 to 72 lakh per year, depending on the age of the child. But in April 2025, the risdiplam generic from the Natco Pharma was DCJ approved after the Delhi High Court denied the Roche's injunction bid in March 2025. And it was also rejected, the appeal, in 9th October. And this brought a generic formulation despite the patent, and is priced at 15,900 per bottle. And this thing, and also regarding the Zolgensma, we already discussed initially. The DCG approval came in August 2025, which has been given a regulatory approval for commercial launch in India for ages, for the 0 to 2 years, the intravenous Zolgensma. And that is something which has to be kept in mind. And the cost of this, which has been there, is around 2.1 million US dollars. They brought it down to 1.7 million US dollars, comes down to 16 crore per the injection. Our patients with the Roche risdiplam, we had all type 1, type 2, as well as 3. Main were mostly 2. And we have had children on bulbar dysfunction and on BiPAP as well. And combination therapy was given in, if you see, 8 had received dual disease modifying therapies. One was on Spinraza, but then he could do a crowdfunding and get the gene therapy was given. 3 received gene therapy followed by risdiplam because these patients were, they were selected by the time they were given that drug. That time they were around 1.5 years of age, and they did not get magical improvement in the milestones. All the improvement was there because there is an ongoing neuronal apoptosis. So as the age advances, because of a neuronal apoptosis, the weakness develops. So that's why in them the gene therapy was given and then followed by risdiplam after the plateauing of the response for the gene therapy, and 4 received risdiplam followed by gene therapy. And there is another patient of ours who was on risdiplam followed by gene therapy, is now after he's been there about a year after gene therapy, and because it's been plateaued now, so we are planning to restart risdiplam as well in the same patient. In the combination therapy, this was a child which I'm mentioning was basically had head control was there, able to sit for a few seconds. He was SMA type 2 with 3 copy numbers. At 1 year, 6 months, they got a loading dose of nusinersen. At 1 year, 8 months, because gene therapy dosing. So had just got the initial loading doses. And now he has developed, you know, independent sitting, and he can pull himself to sitting position. In gene therapy, followed by risdiplam, also we have had few patients, as I mentioned to you, risdiplam followed by gene therapy. So combination is being studied and permutation and combinations are being done. Regarding the intrathecal nusinersen, so I told you that we had 12 and 35, 2 cohorts, and there 11 children have been receiving because one I told you has expired because of, complication, and second cohort is 35, 32 are currently on them. One has expired, one received Zolgensma through crowdfunding, and one patient was lost to follow-up out of the 3 who are lost. No SAE has been reported in any of a patient at all in nusinersen and neither in risdiplam. And intrathecal nusinersen, if you see in the cohort 1, you had predominantly SMA type 2, and the number of doses received, and the baseline and the current HMFSE, which all have shown improvement in milestones. In the second cohort, we again had 2 and 3, and then if you see all in all of them, we had improvement in the HMFSE score in these patients. So you had 2 and 3 in these patients. And to give you an example, this was a child who was given initiation at 4 years, and this was SMN type 2 with copy numbers, SMN2 copy numbers 3, and has a no respiratory or bulbar involvement. See how the child is climbing the stairs, and now the child is able to walk with the walker. So there has been a significant improvement in the HMFSE score also from 20 to 40 in these patients. I'll also give you some older patients who have, this was SMA type 3 after 18 doses, SMA type 3 after 16 doses, another SMA type 3 after 15 doses. So there has been improvement in all the patients. Coming to some of our other data from AIIMS that we have had, an NAIP and SMN2 correlation and SMA phenotype, we found that higher SMN2 copy numbers correlated with the milder SMA phenotype, as we know, and NAIP deletion correlated with the SMN2 copy number, and a lower SMN2 copy number was associated with NAIP deletion. So, and this is something important. And there was another study on neurofilament and creatine as biomarkers in SMA. And we found that the serum neurofilaments level reflect the active motor neuron degeneration was there. And the decline and are highest in the severe early onset SMA, and the decline in neurofilament levels across milder phenotypes of the SMA likely represents disease chronicity rather than clinical improvement. And age and lean body mass adjusted serum creatinine serves as a surrogate marker of cumulative muscle loss and aligns with the clinical severity. And SMN protein levels in peripheral blood show wide variability and poor correlation with SMN2 copy numbers. So that was something which we saw. Then there was a pilot newborn screening for SMA started at AIIMS and the dried blood spot test in SMN exon 7 PCR and cycle sequencing and chromatogram analysis and confirmatory testing by MLPA to be done. And this is one of the first prospective newborn screening trials reported in India, but our patient load of the deliveries is not that much because we have mostly high risk deliveries and also the staff deliveries. The one who are employed here are the normal deliveries and others are on high risk. Something very important is, we keep talking about newborn screening program. It's very important and it is being applicable worldwide and it is being done. But the problem is that in India, when you for anywhere, if you do a newborn screening and identify a child with a particular ailment, then we are supposed to legally and ethically start the treatment for the same because there are prohibitive costs involved from a public health hat if you wear. I mean, from a clinician point of view, I will advocate for a newborn screening program pan India for SMA. But when you wear the public health hat, you cannot say that. So, because we don't have the cost, this prohibitive, we don't have the funds for everyone entirely right now from the government because the rare disease policy limits the funding requirement to 50 lakh per patient. But you see, there is a carrier frequency of SMA is high, which is 1 in 30 to 1 in 40. And you may start doing a population-based carrier screening, which we are not doing, although which is advocated in the United States and even in the European countries. But whoever they are educated and want to get it done, we are doing it. But I think we should have a population-based carrier frequency screening. It's very important to understand. And with these three disease modifying therapies, it becomes important to see. And ideally, it's pre-symptomatic for initiation of therapy. And risdiplam was approved now recently. This thing, Zolgensma has been also removed. So coming to SMA care in India, the strengths and gaps, you have the risdiplam generic also coming and cutting to the annual cost into the range of NPRD. SMA is covered in the NPRD, but it's a ceiling of 50 lakh per patient. But we've had patients, parents, whose parents have got funding for the entire gene therapy from their public sector undertakings, and as many have been able to do from crowdfunding. So there is a gap that there is no fast track pathway from birth SMA testing and the first disease modifying dose and no national newborn screening program, which I mentioned to you about. And we may have a population carrier screening program, which may be more, viable as of now. And, the STEM 50 lakh funding is insufficient and for lifelong therapy. And you have limited centers of excellence on the weak pediatric to adult transition and uneven registries and follow-up structure. Although the centers of excellence are being increased and hub and spoke model is also being postulated for the same. Current cost landscape of SMA therapies. Nusinersen is intrathecal loading dose of, and then 4 monthly maintenance doses lifelong comes to around, 4.2 crore for the first year and 2.1 crore per year thereafter. IV Zolgensma, which is around 2.1 million US dollar. They brought it down to 1.7 million US dollar, coming around 16.8 CR, 16.8 crore. The Roche risdiplam, which is oral daily lifelong, comes around 1.4 crore per year for 73 lakh per year. If you go through the Blue Tree program, support for a 20 kg child. For the NatSmart, there is the plan generic, which is, there with 15,900 per bottle. This we should not forget. Multidisciplinary management with neuromuscular and musculoskeletal evaluation, the orthopedic, the vision, hearing, and endocrine stuff, the cardiac thing, the nutrition, very important. Any swallowing difficulties, reflux, which is the dietary history need for any, G2 feeding, gastrostomy feeding, pulmonary, need to have breathing difficulties, sleep problems, which is very, very important. Need to also add up the psychological support, the social worker, and the immunization status for these children for preventing the respiratory infection-linked respiratory toxicity. Now, coming to the story of the gene therapy, it was initially they did it in symptomatic SMAs, then they did it in the pre-symptomatic SMAs, and then ultimately the FDA had approved in 2016 for SMA. less than 2 years of age, and the European Union had approved in 2020 for children who was weighing less than 21 kgs. DCGI has it's approved it in last year, and it's approved in many more countries which are there. And we have we have this intrathecal SMA steer trial, which was on and which has been completed last year, and it's published in Nature Medicine. In that, we are, intrathecal Zolgensma was studied from, more than 2 years of age, and 2 to 18 years. And now the FDA has approved in November 2025, for the same, for the intrathecal gene therapy. One thing which I mentioned to you is there is a follow-up of milestones of this motor milestones and ventilatory and feeding support. All these improvements which I've seen, they have been shown to last, are durable for at least 7.5 years after follow-up, according to the data. This was a study which I was privileged to be part of, and part of the publication as well, and in Nature Medicine, and which led to the FDA approval on 24th November 2025, and for adults and children more than equal to 2 years of age with confirmed SMN1 mutation of all SMA types. So this is something which is there. So this was the STEER trial, which had shown significant improvement in these patients given intrathecally. And they had a better safety profile because it was given intrathecally and it was bypassing the liver. So ultimately, it was FDA approved on 24th November 2025 for a single intrathecal injection fixed dose, which is weight independent. So this is something which is there. So it was a fixed dose, and it is supposed to be projected at 2.5 million US dollars, but they are still coming out with the final costs. Coming to risdiplam, again, there were studies like firefish in SMA type 1, then sunfish in type 2 and 3, then jewelfish was in the less than 6 weeks of the in the treatment, jewelfish was those who were not naive. They were non-naive, they were given some other treatment, and rainbow fish were the pre-symptomatic one in the first 6 weeks of life. So in the first 3 trials had led to the approval of the FDA, and then the DCGI in more than 2 months of age group. But this rainbow fish and the pre-symptomatic one, which showed that near normal motor milestones at 1 year of age if you are giving them at less than 6 weeks. So that led to the approval beyond for all ages, even less than 2 months. For the nusinersen, there were 3 trials which were there. Initially, one SMA type 1, then it was older children, and then you had the pre-symptomatic. That's how they went for all the SMAs, and they found significant improvement of all these milestones. And they have been also a study in which they were a devote study exploring the higher dose of nusinersen in spinal muscular atrophy, and they found that the clinically meaningful increase in the efficacy above the standard 12 milligram dose when higher dose was demonstrated, and no safety concerns was there. So nusinersen high dose was FDA approved on 30th March 2026, and that gives a 250 milligram per kg loading 14 days apart, and then 28 milligram every 4 months. There have been a lot of studies on the real world scenario of giving gene therapy and giving a mixed match of one after the other of either risdiplam, nusinersen, or gene therapy, and they have shown improvement. Regarding combination, can you combine these therapies which whether can lead to better outcome? Yes, you should apply and use agents which are working at different sites. So you may have SMN2 gene expression one is there, you may have SMN2 splice correction, you may have SMN1 gene replacements. So therapeutic approaches include replacing SMN1 by gene delivery, Zolgensma, correcting the splicing of SMN2 mRNA by nusinersen or risdiplam, or increasing the expression of SMN2 by histone deacetylase inhibitors. So you better to use those who are 2 or more therapeutic agents, generally drugs or biologics, working through the same or different mechanisms of action that are used concurrently, and preferably different mechanism of action. So as I mentioned to you, a lot of mix and match of the various studies have been of the various of these 3 things, combinations, permutation, and combinations have been studied. And long-term data has supported risdiplam as superior alternative to nusinersen in children with type 1 SMA in one of the studies. And there's also another study in Croatia in which they switched from nusinersen to risdiplam, and there was no problem, no deterioration in the function. In another study of risdiplam in SMA after the short-term treatment of nusinersen, it was also fine, and there was a good safety data. how early can you give, So there is a thing, this child, the early treatment of preterm twins. So in that, these twins which were there, and they had three SMN copy numbers. So SD plan was started at 35 weeks gestational age, which was 3 weeks of life. And then gene therapy was given at 45 weeks gestational age, that is 13 weeks of life. And no treatment complications occurred, and both twins reached the maximum CHOP intent score of 64 by 64 by 7 months of chronological age, 5 months corrected. At 1 year follow-up, they could stand, cruise, say 3 words, and were at the 50th percentile for the growth. This was another interesting paper published in the New England Journal of Medicine in February 2025, in which risdiplam was tried for prenatal therapy of SMA. This medication was given on compassionate grounds, free of cost by Roche. And by 32 weeks, 5 days to the delivery, at 38 weeks, risdiplam was administered to the mother. There was no maternal or obstetric adverse events. And then the oral risdiplam was given to the baby from day 8 of life onwards. And this one, they had shown the child had more SMN protein at birth in these children who had already been administered risdiplam. So this is something which has started a new area. Then there have been studies of, using salanersen. Salanersen has been studied, and, you have 4 monthly is nusinersen, but this can be given annually, so that can be more acceptable to these patients. Then there is also a study on, and this already salanersen has been shown to be beneficial, and it has also shown reduction in plasma neurofilaments. As I mentioned, the neurofilaments high in SMN type 1 reduces on treatment. And we also have another study by Biogen on pre-symptomatic children of SMA with salanersen, which has just got started. We are also a site for the same. Apitegromab is a muscle-targeted monoclonal antibody adding to SMN directed therapy, non-ambulatory type 2/3 SMA in a SAPPHIRE trial. And this is something which is there, which is beneficial. And there's also taldigrafab alpha, which is another trial going on, which is a phase 3 myostatin inhibitor is there, which was on. Then there are a lot of new approvals. There was a high dose nusinersen approval, which has been FDA approved on 30th March 2026. Then intrathecal Zolgensma, which was approved in November 2025 by FDA and the European Union on 24th April 2026. And apitegromab, which accepted for FDA approval on review on 7th May 2026. And taldigrafab alpha is missed its primary endpoint at 48 weeks in the broad population, but majority of subgroups showed some benefit. So companies engaging FDA on the next step rather than discontinuing. So for this, a devote and onward, the high dose nusinersen full trial data, and they have shown that, they have in the treatment naive infantile onset, the CHOP intent scores had improved significantly. And in the onward extension, 39 of the 48 patients continue to have and maintain good HMFC scores. So that is something important. And there are no head-to-head comparisons between iTibisma versus risdiplam or nusinersen. So individual patient data from STEER trial when compared to SINFISH and CHERISH there, and it is shown that between iTibisma versus risdiplam, and also, and they've seen in this data analysis that intrathecal Zolgensma or the onsomogene abovuric acid shows broadly similar motor function outcomes to both oral and intrathecal alternatives in this population. And salanersen, as I told you, next generation ASO with yearly dosing is being studied. Then you have one GC101 gene therapy, new efficacy data from China, which has come up, and which is something which has to be seen. Then taldigrafab alpha, and so in that, a majority of subgroup did not show a treatment benefit, but there is a safety was there. So we are trying to study. This is the being studied, and its contrast with apitegromab, which is another myostatin pathway drug, which did meet its primary endpoint, and that apitegromab is under FDA approved. So you have an emerging pipelines. You have GC101, another intrathecal AAV9 gene therapy with codon optimized SMN1. Then you have ANB004, another gene therapy alternative, the apitegromab trial, which is there, salanersen, and there are a lot of repurposing candidates. There are like HDAC inhibitors, vorinostat, phenylbutyrate. So you have vorinostat and phenylbutyrate, then you have neuroprotecting agents like riluzole and gabapentin, myostatin inhibitors like domagrumab and NMG, agents like salbutamol and ROCK inhibition phosphodil. I had initially done 2 trials, one on gabapentin, RCT, a randomized control trial on gabapentin in children with SMA, and another one on valproate and carnitine in children with SMA, another double-blind placebo-controlled trial. Both of them were negative. And right now, the ICMR has sent expression of interest for a study, on salbutamol for the same. Coming to pre-symptomatic treatment trials in the nusinersen one, also the gene therapy one, and there is the PLAM one. All of them, when you had dosed less than first dose was less than 6 weeks of age, they really did remarkably well on the motor milestones. So in the real world evidence also, there was there have been publications in which they're trying to see that, they showed that the ones who were coming out of the pre-symptomatic one were doing much better. They had more independent walking in 64% of screen versus 15% of the symptomatic. In a German cohort of 234, treatment started in the newborn screening at 1.3 months of age. And those who were at 10.7 months in the symptom onset, independent sitting in 90.9% in the newborn screening versus 74.2% otherwise, and independent ambulation was 63.6% in the newborn screening versus 14.7% in the symptomatic onset one. And US data as of January 2024 of all the 50 states screened for SMA, and more than 6 million infants screened by 2022, yielding 513 diagnoses. So screen cohorts have been consistently leading less non-invasive ventilation and tube feeding than symptomatic cohorts. So there have been a new classification of NBS detective SMA in class 1, genetically determined, clinically undetermined, asymptomatic, found only by newborn screening, and SMN copies will be there 1 to greater than equal to 4 and at risk, but no weakness yet. Class 2 is genetically and clinically determined. Infants already symptomatic or subtly so by the time of newborn screening still benefit greatly from urgent treatment. Class 3 is clinically determined and genetically undetermined. Clinical features of SMA with a negative, uncertain newborn screening needs extensive genetic testing plus minus EMG, imaging, and biopsy. So the newborn screening sensitivity of SMN-related SMA is 95%. Compound hyperzygotes and rare biallelic SNVs may be there, and 5% which are missed and present later. Goals are there to treat less than equal to 14 years of life. In the Italian cohort, the mean age at first treatment was 17.3 plus minus 9.1 days. The ethical consideration for newborn screening is screening must link to treatment. That is the most important, as I mentioned to you. And there has to be justice and equity. There has to be informed decision making under time pressure. And there is a risk of overtreatment. And the SMA2 copy number is an imperfect predictor. Treating all more than equal to 4 copy infants early may expose them with a potentially mild disease to costly long-term effects therapy. And resource allocation is very high. Treatment cost raises the question of fair distribution between rare and common public health priorities. So there is a newborn screening in 2026, the global progress and persistent gaps. The 2026 Nature Reviews Neurology commentary says that the newborn screening has changed the diagnostic paradigm for SMA, but uneven rollout across countries is causing inequities within the SMA community. And it's something important. There's a patchwork global coverage includes Australia, Ukraine, and the UK and the United States, along with this India's own limited pilot. You have new time to treatment data, which is there, and mean days to first therapy coming to 11.3 days. In prenatal diagnosis, 24.8 days in newborn screening, and 49.4 days in symptomatic presentation. Better outcomes of motor and have been tracked closely with higher SMN2 copy numbers and earlier treatment start. So screening infrastructure is necessary, but not sufficient. It must be paired with affordable, timely access to therapy to close the outcome gaps. So maybe population-based carrier screening may be important in India as of now. So Better results are seen with gene therapy and risdiplam as well as nusinersen if administered ideally in the pre-symptomatic phase of less than 6. And even nusinersen has shown assuring results when started preferably in the pre-symptomatic infants or in the asymptomatic type 1 SMA. Initiating in later age groups have shown conflicting interest results. This brings to a big question of feasibility, need for newborn screening trials. Safety part is clear as of now, but need long-term data on motor skills. New FDA approval of intrathecal Zolgensma, as I mentioned to you. Now, from awareness to action, the post-diagnostic care pathways needs you have genetic counseling, which is pre and post-genetic counseling, carrier testing, the guidance to the parents, and the cascade testing of the at-risk relatives, the psychological support, the care coordination, treatment linkage, and scheme navigation, active linkage to PMJ and Sehat and the rare disease India Fund, long-term follow-up and community support, teleconsultation, and partnership with parent organizations like SMA Foundation and the FACT. And there is a CSR and community support should be there to closing the access gap. India has an estimated, 50 to 70 to 96 million people living with rare diseases. Most face a post-diagnostic gap as a label, but no roadmap, coordinator, or next step. CSR funding works best as complete care pathway packages. Example, one genetic counselor plus one patient navigator and a teleconsult system rather than one-off donations. 80 plus rare disease patient organizations in India, examples, SMA Foundation of India run peer support groups and help families navigate the PMJ and RDIF entitlements. The National Policy for Rare Disease 2021 and the Rare Disease India Fund give the policy and financial backbone. CSR partners and clinician-led centers of excellence must convert this into care on the ground. So to conclude, the most important mechanism for treating SMA children include replacement of SMA gene therapy, SMN2 splicing modifiers, and antisense oligonucleotides, risdiplam, nusinersen, therapies to upregulate muscle growth, myostatin inhibitors, neuroimaging therapies, and SMA have shown favorable results in improving short-term functional outcome. Post-gene therapy, mild asymptomatic transaminitis, and thrombocytopenia are common adverse effects which are there post-dosing but managed by oral steroid course. I have had to give steroids, which is supposed to be given from 1 day prior to giving the gene therapy to at least 30 days. I have given up to 6 months, up to 6 months period because you have to closely follow these patients of the transaminitis and may need a slow prolonged taper. And intrathecal nusinersen and oral risdiplam have to be administered lifelong. Combination therapies need to be explored. Number of serious respiratory illnesses have also been reduced in the population under follow-up in all the 3 drugs. More data required regarding the long-term outcome, and the common denominator for all these 3 drugs is the high prohibitive costs that make the treatment challenging in the Indian subcontinent. Thank you so much for patient listening. This is my team, and this is Institute in the Broad Sunlight and on the Foundation Day. So I very acknowledge the support by, most importantly, the children and family who have given an opportunity to treat them. Thank you so much. I'll be happy to answer any queries and questions.
Dr. Sheffali, thank you so much for the excellent talk and taking us through the history of disease modifying therapies and what we need to look forward to. I'll just look at what questions are there in the chat box. And so one of the questions is, what is the experience with the generic risdiplam? So how, what, the cost is significantly less, but clinically, is there any studies or to say that how it's doing?
No, there have been no studies till date, and there have been no comparative trial or any bioequivalent studies about the generic risdiplam. So we are not aware of anything. Nothing has been published, and nothing is there. They don't have that, but they made the same molecule. That's about it. And the DCGI had approved its marketing, but it's the clarity is not there regarding the. There's no test available. Yes, but right now, practically, what is happening anywhere in the far away, anywhere across country, parents come to know the diagnosis of SMA because although it is 15,900, but it is obviously much more affordable than the 6 lakh bottle, right? So parents are starting and they are giving. So we'll have to just see, on follow-up as of now, but there are no studies which have been done.
The question was that is it available under the NPRD and in the centers of excellence?
What? The
The
NATCO?
generic, the NAT.
Yeah, the generic one, the process is on. The process is on. We are waiting for approval from the Ministry of Health. We are waiting for instructions from them. They are having discussions with the DCGI, and till now we have not been able to procure it. But we are waiting for approvals and the proper procedures to be put in place.
Ma'am, this is a question from my side because there were no other questions in the chat box. So meanwhile, still someone typed.
We have questions
Another
in
one?
Q&A.
Oh, sorry.
Q&A.
Oh.
I can. First question is what in the Q&A is the newborn screening, can it be covered from NPRD? Right now the government is not asking for a newborn screening, so it is not there in the NPRD. Is iTibisma being given in India? Yeah, we were part of the STEER trial, and there were two or more sites, and we had given to 7 patients in India, but that was as a part of the trial. But right now we are waiting for the Novartis to prepare their delivery network and supply to India. So we have some patients already waiting. What information we have is we'll come to know by October end, and then we can administer, because we have already done as part of the trial. It's to be done under fluoroscopy guidance intrathecally. So that is there. Then somebody's written, I'm from Kashmir. My daughter is 13 years old. And was diagnosed with SMA type 3 before 2 years in Kashmir, and later went to AIIMS. There is registered NPRD, but till now I didn't get any latest information about any scheme. I started RISD plan June. Yes, that's what you can understand. I told you we have not been able to procure the NATCO one as of now. We are waiting for approval from the ministry, as well as there are operational issues which are there, which are being handled by the medical superintendent for their procurement. And then there is somebody's written that my niece has 7 years with SMA 2. She's not able to walk and body is weak, and my family friends are not. What can I do? Yes, you can go and register yourself into the rare disease, the center of excellence, and uh, uh, and we can start on the treatment. But regarding the generic one, which I told you, we're waiting approvals and indications once it is done. So you can at least get and show, and you put your papers. So we also put all papers of our patients here. We're just waiting for final approvals for the same.
Some few other questions were that is there any for the doctors, is there when patients come, how do you decide if it's the one thing is financial, of course, but the risdiplam or the nusinersen or gene therapy, what is suggested? Is there any guidance on that?
Yeah, we counsel the patient for all the 3 options and let the patient decide. We cannot decide for patients, but we give the entire. So whenever any patient is there, so besides emphasizing all the multidisciplinary care, and we have our PTOT and the dietitian and all they see them and guide, but we explain the parents the 3 options and their cost, and that's how we proceed. So we can't decide, but we have to give them information. And if you have seen, after our experience of 26 gene therapies intravenous and 7 intrathecal, which I didn't mention because it was part of the trial, I cannot take out data from the trial separately. Although I did mention the trial result, which showed, I mean, I just gave the gist of it. Then out of the 47 patients on nusinersen and 19 on risdiplam with 8 on combination, we found, all of them are working similar. Obviously, the mode of administration is different. You may need to give the intrathecal one lifelong and, 4 monthly, but salanersen is coming up, which is annual. And otherwise, the problem with risdiplam, it's very easy to give and all, but sometimes some parents don't want it lifelong. They want something to finish. So what people are generally doing is, what I'm noticing is most of the people once diagnosed are starting on NATCO. Yeah, and it's very few who are affording can start on every city, and they are waiting, and so I mean, for starting. Most of them try for, what I have seen is they try for crowdfunding because they ask for prescription for the same crowdfunding and getting, sources like there are other sources if somebody's working in the public sector organizations and all. But people do try because I feel they want a one-time result, which is there. But what was important is to see is that it's been so interesting that people have started giving an antenatal mothers as well, and so we can understand that what to you know how to see, like the counseling is also become different because of that. And I think short of the newborn screening, population carrier screening is something important which India should consider. I think that will be something important because newborn screening, the roadblock is only that you need to treat, and the treatment is expansive. It's much beyond the 50 lakh.
Mm.
So, I said as a cap, wearing a cap of a pediatric neurologist, I want newborn screening to be started right now. But wearing the hat of a public health point of view, when I am in the meetings in the ministry, then we cannot do it. I mean, till we get the affordable ones. Yes. But one thing is important, one message is that we should have a good genetic counseling, and we should have a good genetic counseling and a prenatal diagnosis for future pregnancies, because I see many of my parents have more than one affected sibling, which I feel is a failure of the medical fraternity as a whole. If in 2026, if you have the same problem in another child in the same family, I think we have failed big time.
Yes.
And we have to also remember that we have to not only the child. I think that in the counseling, it's very important to guide the parents about the chronicity of the care, and give explain them coping strategies. And ultimately, we need good transitional clinics, and we need good palliative care stuff for those who are really sick. And I think there has to be some respite centers across India in later on, because there is a limit to which the parents will also have a burnout.
Parents.
Yeah, so I think, and I, as a short of that, I keep telling most of my parents that you should please, you can have a buddy system that you can communicate, and you can be there with your friends of the similar thought processes, similar education. You're living in a similar place, so that you can do a buddy system that when you need, and mostly we are nuclear families, most of them are working, so then we can provide support to each other family. So at least short of the having respite centers, because our country is huge, lot of problems, we can have this kind of a buddy system which may help and support each other. I mean, we have to help and support each other. Another thing is we need to understand that it has to be a humanistic view of everything. Each life has an equal right to dignified life in the world, and no life is less valuable than other.
One final question, because it's going to be 5 o'clock. One thing was that post getting access to this disease modifying therapies, the follow up, like I'm a pediatric pulmonologist, so a lot of time I think here we also have quite a few patients on gene therapy or risdiplam or have received nusinersen. I'm at Bangalore. So, we struggle. The follow up that, how do you like ensure that they're following up with the pulmonologist, or what all follow up is needed? Because there's some parents here, and if some of them have received any of these drugs, so how do they follow up, and what is the importance of a follow up?
The importance of follow-up,
Various multidisciplinary
yeah,
teams.
yeah. One thing is that, especially with Zolgensma, you need a very intensive follow-up initially post gene therapy. So we have a WhatsApp group with the families of Zolgensma. Each gene therapy out of the 26, I have 26 different WhatsApp group with their families. Because they should be able to access us anytime, because there may be complications. As I mentioned to you, transaminitis was there in all. So that you have to have initially closed follow-up, and getting those blood tests done weekly is very, very important. But later on, ensuring the nutrition, the physical therapy, respiratory therapy, and even for the child who's cognitively preserved, for their coping strategies, and they're feeling, they're feeling not feeling less than others, and trying to motivate them, and see whatever support you need from the various physical and respiratory therapies and the sleep studies that needs, and we need to follow them up closely. And I think most of the patients do follow up. in the thing. And somebody was asking preconceptional SMA carrier screening. That is what I was talking about. Population-based screening is that. So if any parent is coming, you please get the screening done. And if they are carrier positive, then you can they can have a prenatal diagnosis even in the first pregnancy. And the other one is that if your clinical criteria, choose from palliative and curative. There's no clinical criteria. I mean, we understand somebody who's been on, ventilatory support for very long, having severe bulbar dysfunction, having feeding difficulties, respiratory infections, and all, and nothing is improving. So, I mean, those situations you go to, but there's no definite clinical criteria. It is your clinical judgment only. And but because of this disease modifying therapies, you need more transitional care also, that the pediatricians have to transition the care to the adult neurologist for those who are growing up. And you may need orthopedic care because scoliosis becomes an issue later on, and so that is also you have to see the all aspect of the child, and the nutrition, growth, vaccination, everything to be seen.
And thank you so much for the excellent talk, Dr. Sheffali. And I think all the doubts were clarified. I think when I was writing questions through the thing, then the subsequent slides, all the queries or doubts that even I had in my mind were clarified. So thank you so much.
Thank you.
Dr. Prasanna, Mr. Prasanna.
No, nothing else. You just go ahead. I think we have completed on dot 5 o'clock. Thanks so much, Doctor. Yeah.
Thank you. Thank you so much. Thanks.
Okay. Thank you. Thank you.
Thank you. Thank you. Bye-bye. Bye.
Thank you, everyone, for attending.
Thanks.